indirect. Let's go on to study the optics, how the indirect ophthalmoscope works. Because if you don't know how the machine works, you will never be proficient in doing the technique. So to be proficient in doing indirect ophthalmoscopy, we should know the different parts of the indirect ophthalmoscope first. And for that, we have invited Dr. ABHISHEK Kedia, who is a prolific VR surgeon in Patna and Ara. And he'll be speaking to us about the optics of indirect ophthalmoscope.
Thank you, Dr. Pooja, for making me part of this IC. And it's very important to know the machine on which you're working. So it definitely sounds boring, but it's not so boring. We just need to know few important points, which I have tried to simplify, and let's look into it. Okay. So this is an indirect ophthalmoscope, and I'm just trying to bring the pointer. So this is the illuminator, which is the light-giving part to the examination, and this is the headband. So this whole thing is headband, which has got knots on the top and on the sides, so that you can adjust the size according to your head. And so the main thing is this illumination, which has got various knots and apertures, so that we can change the light, and we can move the beam like this one. We can, with this help of this, we can move the beam up and down. And here there are knots which you can use to change the color and the size of the beam. And on the bottom we have aperture, which we can reduce. So suppose a patient is having small pupil, then you need to reduce it to small pupil, and if it's the well dilated, then you need to make it to a slightly larger size. So it was introduced by Nagel in 1864. The principle is nothing. It's just we make the eye highly myopic by placing a high power convex lens in front of the eye, so that we get a real, inverted, and laterally reversed image. So it's real, inverted, and laterally reversed. And the image is formed close to the principal focus of the lens, between the lens and the observer. And this is called indirect because we are observing the fundus through a condensing lens, not in observing it direct. Now coming to the very important principle, Gulstand's principle. This is very important to have to get a good view. So this principle is nothing. It just says that the viewing beam and the illuminating beam, that should be separate. It should coincide on the retina, but the illuminating beam goes through the pupil, cornea, pupil, and then travels through the lens, and then gets focused on the retina. The same beam gets refracted back, travels through the lens, the pupil, and comes back to the observer's view. But these two should be separate. If they coincide, then it's very difficult to get view, and you get a lot of reflections. So they should coincide on the retina, but they should not overlap. And the binocularity is achieved by the help of prism and mirrors. So the observer's interpupillary distance, which is approximately 60 millimeter, is reduced to 15 millimeter by the prisms and mirrors. The advantages of indirect ophthalmoscope: it gives stereopsis. The field of view is larger as compared to the 90D or 78D biomicroscopy. The illumination is bright. So, and there is minimum peripheral view distortion if you do it properly. And we can have a complete eye examination with the help of scalar indentation. And it's independent of patient refractive error or moderate media opacification. So this is the 20 diopter lens. So the important thing to keep in mind is that when we are examining the patient, the silver lining on the lens should be facing the patient's eye. It should not be on the other side. So this is the examiner doing indirect ophthalmoscopy. So as soon as you put it on the head, adjust all the settings, and then you put the light on the patient's eye, and then just bring the lens in front of the eye, and then just bend backwards, and then adjust the light accordingly so that it goes directly into the eye, so you get a good view. These are the various lenses which you can use. So 14 diopter gives a magnification of 3.8 times. The 20 diopter gives a magnification of 3 times, and the 30 diopter gives magnification of 2.1 times. This is a small video to make things revise and just for a better understanding how we examine.
The optics and principle of the indirect optoscope. I'll just show how you have to fix the indirect and how you proceed. So first you fix the headgear. You have two knobs, one at behind and one up. This basically fixes the depth, and once it is properly adjusted, then you focus the beam on the wall or on your finger, and after this you have to adjust the IPD so you can have good binocularity. So you close one with your one eye and see whether this beam is in the center of this viewing system, and then I'll close the other eye and again repeat the same thing. After this you open both your eyes and just adjust your IPD properly. So with this then you start the procedure. So now before starting the procedure and demonstrating how you do the indirect optoscopy, I'll just briefly go through the optics of this. So the basic concept, whole concept of indirect optoscope is you have to make the eye myopic by placing a high powered convex lens, that is the condensing lens, in front of the patient eye, and this results in seeing a fundus image which is real and inverted. So since it is the indirect viewing of the fundus through the condensing lens, so we call it indirect optoscopy. And while we see the patient fundus, one very important principle comes into play, that is called Gould-Strand principle. So what is Gould-Strand principle? The whole principle says that the illuminating beam, that the beam which passes from this indirect optoscope, this illuminating beam, passes through the cornea, pupillary aperture and lenses and goes in the retina, and from there it reflects back and comes through the same pathway that is lens, pupillary aperture and cornea. While going and coming out, both stays parallel, they don't coincide, because if they coincide, then there will be scattering and reflection and we won't be able to see the fundus image. So whole concept is they will lie parallel and meet only at the fundus, so that we can see the image. And then while we place the convex lens, so this image which is coming from the fundus gets focused on somewhat near the principal focus of the condensing lens, which is between the observer eye and the condensing lens. So this is the basic principle of indirect optoscope. So to start how you start basic procedure, you need on paper this diagram. This is basically for drawing the diagram. Whatever you see, you just note it down here. Now, this paper you place it beside the patient head or just here, and you have to remember that 12 o'clock position. It's marked here 12. It should be facing towards 12 o'clock. 6 o'clock towards 6 o'clock. The whole concept is when you see the patient, suppose when you see the patient, अपना ये हाथ उठाना, ये उंगली तक देखना है. This is done so that he can, because with bright light he won't be able to see his finger, but he will have this spatial orientation of his finger, so he can focus it properly. And when you see this patient is focusing there, and you place your condensing lens. Now the concept is whenever you use this lens, this plays as the fulcrum of the pivot. With this you move your lens. You have to hold your lens like this, and this finger acts as a pivot or fulcrum. And with this you can move up and down near to eye and far away from the eye for a proper focusing. And you ask the patient to look in the desired direction. You just ask him to look to this finger, and then you focus on his eye. Now whatever you see, the basic concept is whatever you see, what you see near to you, you draw on this fundus picture. You are seeing this this is the 5 o'clock position. You are seeing the 5 o'clock position. So you just see where is the 5 o'clock position, and whatever you see near to you, draw near to you, and what is far off from you, draw it far off from yourself. When you place it properly, you will see it is properly aligned. You won't have any confusion of this real inverted, whether it is in the 6 o'clock position or 12 o'clock position. Just you remember, this is 5 o'clock position. You see this is 3 o'clock position, so you come on 3 o'clock position. This is 12 o'clock position, so you concentrate on 12 o'clock position. Whatever you in 12 o'clock position, whatever you are seeing far off from yourself, draw it far off in the diagram. Whatever is near, draw it near. So this way you complete the whole examination. So hope I am clear. Thank you. Before
Thank you. So I think that video must have made the optics and the examination technique more clearer to you.